Hi, everybody. So my name's Jill Plonsker. I am a chief resident at UCSD in neurosurgery. So I'm in my 7th year of training. I'm originally from Chicago. I spent a little time out in Boston and then did my training back in Chicago, and now I've been out here for the past a little over 6 years. I have a lot of experience, I think, over the last few years managing Chiari malformation. I spent 20 months with Dr. Levy on the Pediatric Neurosurgery Service. And we see lots of Chiari malformations in adults as well. So my talk today is going to be about the differences in presentation and management between adults and children with Chiari malformation, or at least my experience of it. So I know we have a mixed audience here today. I just wanted to talk a little bit briefly about some different brain anatomy. So over here on the left, that's just a picture of your brain. There's a brain stem and then a cerebellum, which is really our area of interest here, because in Chiari malformation, those two structures start to herniate through the hole in the bottom of your skull. So things like the brainstem and the cerebellum can get quite compressed. The brainstem controls a lot of really important things, like all of the nerves from your brain go to your entire body, controlling how you breathe, how your heart beats, how your arms and legs move. Your cerebellum is a little less critical, but it controls how you coordinate those movements. Okay, so compression of those structures can cause quite a few symptoms, not to mention blocking of the normal fluid pathways of the brain, which can cause things like hydrocephalus. So how does Chiari malformation present in pediatric and adult patients, and how do the structural abnormalities in the skull base and its contents correspond to the symptoms and outcomes in these two different but similar populations? That's what I'll be talking about today. Chiari malformation can exist across our lifespan. So often in pediatric neurosurgery, we talk a lot about Chiari malformation. We love to talk about it in all of our conferences. We publish on it extensively. But children with Chiari malformation become adults with Chiari malformation. Okay? So these patients are patients throughout their entire lifespan. Not to mention we have many, many adults who present with Chiari malformation. More typically, what I'll talk about, it's more likely to be a Chiari 1 malformation, which looks a little bit different. But a lot of these patients had this Chiari malformation as children, and it was just found as adults. So this is a lifelong disease and a lifelong management paradigm. These different types of Chiaris are categorized based on specific structural differences, and we actually categorize these Chiari malformations into multiple different categories, which I'll go through. So structure leads to function, and depending on which portion of the brain or the brainstem are involved in this malformation can vary how the patient's going to present. So this is a lot of information and a lot of pictures. The two most important ones, or the two most common presentations, are going to be the Chiari 1 and the Chiari 2. So Chiari 1 is what most people in the population are familiar with. This is the abnormal descent and herniation of the cerebellar tonsils through an opening at the bottom of the skull, which is called the foramen magnum. So I know it's really tiny on the screen, but you can see the cerebellum is just dipping below the skull base, causing some crowding of that space at the foramen magnum. Chiari 2 malformation, by definition, is associated with myelomeningocele or spina bifida. So all of these patients are going to have spina bifida or some variation of that. There's multiple different structural abnormalities associated with the Chiari 2. So we talk about things like tectal beaking and herniation of the medulla or the lower brainstem through the foramen magnum. Chiari 1.5 is a little bit newer of a designation. This is something that we like to, when we like to name things, we look at pictures and we like to name things in medicine. So it has a lot of structural or anatomic features of a Chiari 2 malformation, but without the clinical association with the spina bifida or myelomeningocele. Chiari 3 is a little bit different. This picture obviously looks quite different. There's a big balloon on the back of this child's head that's called an encephalocele. So there's a failure of closure of the skull or the brain, usually along the midline. About 80% of these are going to be in the back, but it can be anywhere along, and it can even be in the nose, where there's going to be a defect in the dura, and the brain, or just the lining around the brain and fluid, are going to herniate out and create this big bubble that we have to treat surgically. Chiari 4 is a little bit controversial, but it can be the absence of the cerebellum. So it's not really herniation through that defect, but this right here is a picture of a child with a Dandy Walker malformation. So Chiari malformation is not just a Chiari malformation. It is a spectrum of symptoms, and it's a spectrum of structural abnormalities. So this here on the left is a picture of a syrinx, which is the abnormal dilation or fluid collection within the spinal cord. Myelomeningocele, or spina bifida, is, again, a range of clinical conditions associated with failure of closure of the neural tube defect, typically in the lumbar spine or the sacral spine. And here you see herniation of the spinal cord and fluid and dura all through an opening in the skin and opening in the bone and muscle. I'll show you a few pictures of these later, but these can either be open, meaning that they're draining fluid into the outside world, which is something that we need to treat surgically pretty urgently, or they can be closed and covered with skin. So again, structure leads to function. So the common Chiari symptoms depend on what type of Chiari malformation patients have. So like I said, a Chiari 1 malformation, it's estimated that about 1% of the population actually meets diagnostic criteria for a Chiari 1 malformation. It is extraordinarily common. My mom has a Chiari malformation that she found when she was getting an MRI for something totally unrelated, and it's completely asymptomatic. About 70% of these patients are completely asymptomatic. That said, some of the more common presenting symptoms are going to be a very specific type of headache. So it's typically occipital, meaning it's in the back of the head, and what we call tussive, meaning that when you suddenly increase the pressure in your head, meaning you're coughing or bearing down or straining in some way, that's what's going to bring on the headache. There can also be associated with some motor and sensory deficits. We often talk about a cape-like distribution of numbness in the shoulders and upper extremities. Depending on whether or not there is a syrinx associated with the Chiari malformation, you can also have some balance and gait, issues, and difficulty walking. Chiari 2 malformation, you're going to have more symptoms associated with the herniation of that brainstem, that really important structure through the foramen magnum. So in small babies, that can be something like central apnea or difficulty breathing, also difficulty swallowing. And hiccuping can often be related with the Chiari 2 malformation symptoms. Upper extremity weakness and syrinx are also associated with Chiari 2. Chiari 1 and 2, you're going to start seeing some symptoms of both, and then Chiari 3 has completely to do with that encephalocele. All right, so now let's break it down into these different patient populations. So when we talk about children and we talk about adults, it really depends on what is causing the patient to come into our clinic. So with a pediatric patient, Chiari 2 malformations are sort of by definition, it's a very obvious thing. It's a skin lesion. So these patients are going to show up on day 1 of life often, or even prenatally, they're going to show up in clinic. So Chiari 2 malformations are often diagnosed much, much earlier. Chiari 1 malformations, we see adults all the time who floated around for years with headaches that were undiagnosed, or that nobody really thought to image them for a Chiari malformation. So that's actually quite common, that adults are going to present much later, and that's usually going to just be a Chiari 1 malformation. Pediatric patients, males and females, are about equal, but Chiari 1 malformations are much more common in female adults. So some studies say 57%. I've seen other studies up to 80% of Chiari 1 malformations are women. There's 2 different peak ages of onset. So pediatric patients or kids with Chiari malformations are usually going to present between 8 to 9 years old, and adults are going to usually present sometime in their 40s. At least that's the median. Syrinxes are going to be more common in children, although also quite common in adults, and usually is a major motivation for surgeons to choose to operate. So when you break these studies down into operative patients, or patients who are taken to the operating room to treat their Chiari malformation, it's almost more common in adults to have had a syrinx. So that's a major motivator in adults for surgeons to take those patients to the operating room. Complications are about equal. We'll talk about that a little bit later. And mortality is very, very low. So there's different symptoms that show up in children. In pediatric patients in particular, and I know we have some other talks on this, so I will not belabor the point. Pediatric patients are more likely to present with scoliosis. So we see lots of kids show up in our clinic as referrals from the deformity surgeon clinic because they're starting to develop a scoliosis. And when they image their spine, they get an MRI of the neck, which shows a Chiari malformation. So the spine surgeons will ask us to do a Chiari decompression in the hopes that this will improve or reverse the scoliosis. Adults have much more mature spinal anatomy, so are much less likely to develop a scoliosis later in life as a result of their Chiari malformation. And also children, of course, are going to show up to our clinic with neural tube defects much more commonly than adults will. Like I said before, adult patients will tend to show up more with these tussive headaches as the most common presenting symptom. Scoliosis is going to be much, much less common. So these pictures over here, these are just some pictures of a scoliosis, which can, like I said, can be related to the Chiari malformation. These pictures down here are both different types of neural tube defects. So like you can see, these are very obvious skin lesions, and these children are going to show up immediately to see the neurosurgeon. This is a really important point, I think, and this is something we actually like to talk about in modern day medical school quite a bit, is how unconscious bias among providers can lead to delays in presentation and delays in diagnosis. So given that women are much more common, it's much more common to have a Chiari 1 malformation in women, unconscious bias about women and pain can unfortunately lead to significant delays in diagnosis. So patients who show up to their PCP with a headache may get sent to a migraine doctor, may get sent to a headache specialist, a neurologist for years even before somebody thinks to get imaging of their head, okay? So this is something we really need to pay a lot of attention to, not just in neurosurgery, because by the time you show up in our clinic, you usually have a diagnosis, but in medicine as a whole, that when people have symptoms, particularly pain, which is a much more nebulous symptom and not quite so easy for people to diagnose, especially if they're not familiar with Chiari malformation, it's super important to start thinking about these, and organizations such as this are really critical and really important for raising awareness, especially among primary care providers and patients so that they can advocate for themselves. So I'm going to transition a little bit into talking about how we manage these patients. A Chiari decompression is a Chiari decompression. It's actually quite similar in adults and children. So I know there's been many talks today about how this is managed, so I won't go through it too much, but when we do a Chiari decompression or a suboccipital decompression, we remove the bone from the bottom of the skull. We also remove the back of C1. So these pictures on the left are a side view, and these pictures on the right are as if you're facing my back. So we take off a little window of bone at the foramen magnum and really widen that out, and then we take off the back or the lamina of cervical 1. Okay, this doesn't create any instability if we stay right in the back, and the entire goal of surgery is restoring the normal flow of cerebrospinal fluid across the foramen magnum. So we're creating more space, okay? So if your spinal cord is contained in a house, we're just expanding the house and taking the roof off the house to make more space for everybody inside, okay? There's a few different steps after this, and I'm going to go into this a little bit more, the question of whether or not we do a Duraplasty, and that is actually a little bit different between adults and children, what providers tend to do, but that means that if we didn't feel like just opening the bone created enough space, then we open up the dura and we put a big patch in to create even more space at the foramen magnum for CSF to flow. Chiari 2 patients is very, very, very different. So they teach us this in residency over and over and over again, that if a patient with Chiari 2 comes in with Chiari symptoms, the way you treat it is you fix their shunt. Because Chiari 2 patients very frequently, I'd say more than 90% of the time, have ventricular peritoneal shunt and hydrocephalus, and a Chiari 2 patient can present with Chiari-like symptoms. So the first, second, and third try is usually revising the shunt before you consider a Chiari decompression in a Chiari 2 patient or a myelo patient. At our institution at Rady, we do try to avoid doing a Duraplasty if at all possible. This gets debated up and down in the pediatric conferences and in the literature whether or not doing a Duraplasty is required. So our workflow is that we will do the suboccipital decompression, we do the bony decompression, and then we'll take an ultrasound and we'll actually look to see if that restored CSF flow across the foramen magnum. Now, if we feel that just based on our bony decompression, we can look through the dura with our ultrasound and there's really good flow across the foramen magnum, then we'll stop there. If we don't feel like that and we actually don't see good flow across the foramen magnum, then we'll proceed with the Duraplasty. The only exception to this is if there's a syrinx or if the patient comes in with a syrinx, then we will just about always do a Duraplasty because those are much more likely to fail. Now, like I said, there's been many, many studies about whether or not it's very important to do a Duraplasty. I think the common finding is that people don't really know what the best thing to do is. It's more effective typically, it's more definitive to do the Duraplasty up front. Those patients have a much lower rate of needing a reoperation or a second surgery. However, it has almost an 8 times higher rate of complications. Okay, so patients feel a lot better after surgery, they go home a lot sooner and have a much lower rate of complications if we don't do the Duraplasty, which is why we try to avoid it if possible. These pictures here, so this is just a picture of what the Duroplasty looks like. This patient on the left is a very small child with a very severe Chiari malformation. This picture here is what a Duraplasty looks like. So here's the dura right here. This is normal dura. You guys can see my mouse? Yep. This here is a synthetic graft. So you can use synthetic grafts. You can use non-synthetic grafts. There's multiple different options that surgeons can use. And we use a combination of staples and stitches to create a watertight closure to prevent cerebrospinal fluid leaking from that graft. Just going through the postoperative course for Chiari malformation patients. So like we talked about, there's first the operative decompression, which is pretty similar between adults and kids. Pain management after surgery is, in my experience, quite different. So adults are a lot bigger than kids. They have much more developed neck musculature. And so doing the surgery, we have to go through all those muscles in the back of the neck, and it can be quite painful for adults. It's painful for kids too, but adults struggle from pain just because of the development of those neck muscles. We use a lot of numbing medication, but muscle relaxants tend to be the mainstay of my postoperative therapy for these patients. Not to mention, adults have a very different experience of pain than children do. I think children in a lot of ways are not very good at describing what their pain is, and are really distractible in ways that adults sometimes aren't. So adults can have, especially after just a Chiari decompression or suboccipital decompression, can have a much longer postoperative course. Surgery can be a little bit more painful than for kids. We do physical therapy after surgery, and then based on how physical therapy goes, we make the appropriate recommendations for outpatient management. For follow-up, there's really no substantial differences between our follow-up after a Chiari decompression between adults and kids. I'd say if a syrinx is present, we don't expect that syrinx to get significantly smaller right away, but we'll repeat imaging in 3 to 6 months. So, looking at a few different studies and surveys of surgeons and how they manage the suboccipital decompression and possible Duraplasty. Just about everybody, whether you're an adult or a kid, is going to get the bone off. That just makes sense. That's the basic part of the surgery. Surgeons are much more likely to do a Duraplasty 97% of the time, meaning that they open the dura and put that patch in adult patients rather than kids. Opening of the arachnoid is, some people harp on that, whether that's an important step in the surgery. Usually that's just involved in opening of the dura. And then the last step is whether the cerebellar tonsils, when they descend really far into the foramen magnum, you can also make the decision to coagulate them and shrink them back to create even more space. And that's more commonly done in adults, but is not done all the time. I'd say less than a quarter of the time in adults and children. And then, as it makes sense, kids are much more likely to end up with a shunt due to their Chiari malformation or in relation to the Chiari malformation because of the spina bifida population. So we see a slight divergence in complication management between children and adults. Complications overall are extraordinarily rare after this very common surgery. It's a very safe surgery. When we do a Duroplasty, that's when we start to see the complications rise. So the biggest risk is cerebrospinal fluid leak. We see that about the same rate in adults and children. The reason for this is that if there's an association with hydrocephalus, that increases the pressure. And when you have an increased pressure of fluid, water is going to want to go down the path of least resistance. And the path of least resistance is going to be the incision you just made in the dura and the incision you just made in the back of the head. So no matter how many stitches we put in and how good of a closure we do, sometimes there is going to be an increased risk of that fluid going through that suture line as opposed to staying inside the head. Okay? Whenever there's a CSF leak, there's an increased risk of having meningitis. So this can be an infectious meningitis, and that is seen about the same rate in adults and children. There's for whatever reason this is, there's an increased rate of pseudomeningocele, meaning there's a fluid collection under the skin that doesn't leak out of the skin. That's a lot more common in children. Neurologic deficits, extraordinarily rare, very, very rare in both adults and kids. The really good news about this, though, is that surgery really works. It really works for both adults and children. So headache resolution in children is about 88%, and in adults it's 73%. So slightly better in kids. Part of that is just the multimodal contribution of headaches, and there's many different reasons that adults can have headaches, a little bit less common in kids. But still, almost 3/4 of the time, people are going to see complete headache resolution after surgery. Same thing with preoperative neurologic deficit. Children do slightly better than adults, but overall, everybody does really, really well. And same thing with Syring's resolution. So Syring's resolution, which is an objective measure, we look at it on an MRI and see in 3 to 6 months later, did that Syring's get better? Almost 80% of the time in both adults and kids do we see some resolution of that. So this is really good news, that this is a complex problem with a nebulous presentation in adults and kids, but everybody does really well after surgery. So just to summarize, because I'm running out of time here, kids are not small adults, and you hear that in all sorts of pediatric disciplines. People love to say that, and it's absolutely true. Kids are slightly different than adults. Part of this is how they're going to present is really, really limited on how they're able to communicate their symptoms. Okay, so if you start seeing kids having tantrums and then holding the back of their head, they may not be able to even communicate or understand that they're having a headache, or they may not understand even what numbness and tingling is and able to communicate that to their parents, which is why we start seeing kids present much more with these objective findings, meaning that they're falling down all the time, or they have a scoliosis that was picked up by their physician, or they have a neural tube defect. So that's a huge limitation for kids coming in for Chiari malformation. The symptoms differ across lifespan. So because of those reasons, scoliosis and neural tube defects are going to be much more common in children, whereas that classic tussive headache and pain is going to be much more common in adults. The patient's presentation and what their imaging look like is just going to be the most important rationale for why the surgeon decides to do what they do. So whether that's placing a shunt, whether that's doing an endoscopic third ventriculostomy, which we didn't talk about today, but is another treatment for hydrocephalus, or doing the suboccipital decompression with or without Duroplasty, and how extensive that suboccipital decompression is going to be. Again, shunts are more common in kids, about 2 times as common. And the really good news is that majority of patients have symptom resolution, whether they're children or adults. Kids do slightly better. Kids are really good at healing. They're just built better than we are. But everybody, including adults, tend to do really well after treatment. And I think there's a lot of opportunities for increased awareness, which, again, this conference is a really important factor in, is increasing awareness to both patients, people with headaches, migraine patients, and providers to help diagnose Chiari malformation earlier and get patients to treatment that is helpful. And pediatric patients, of course, will require some multidisciplinary care associated with their presentation. So we work very closely with orthopedic surgeons, who you'll hear from in this conference, I know, and primary care providers, neurologists, and pain specialists. So that's all I have today. Thanks so much, and I guess we'll sit for the Q&A session now.